this Thursday morning. I'm Ava Kadiwada. I'm one of the internal medicine chief residents this academic year. It's my pleasure this morning to introduce Dr. Luis Batista, who will be introducing our speaker. I will go ahead and hand it over to him right now.
Hi, everyone. Good morning. It's a real pleasure for me to introduce Sharon Savage today. I've worked with Sharon for many years now, starting actually from the beginning of my postdoc when I was still in Steve Nartandi's lab. Sharon is a recognized leader in the field of telomere diseases, and she's currently the chief of clinical genetics of the clinical genetics branch, as well as the clinical director of the Division of Cancer Epidemiology and Genetics at the NCI. Sharon got her MD degree from the University of Vermont College of Medicine, followed by a residency in pediatrics at the Children's National Medical Center in Washington. Sharon then did her fellowship in pediatric hematology and oncology at the NCI and Johns Hopkins Joint Program. I believe it was during this period that Sharon began her postdoctoral training with Blanche Alter at the NCI, where she eventually started her independent research career in 2006. Sharon has too many awards to mention, so I'll not do that here today, but I would just like to highlight that she has recently received the Outstanding Mentor Award at the NIH, which I really believe speaks loudly to her amazing persona and respect when dealing with her colleagues. She is a major contributor to the field of bone marrow failure and genetic instability, having found many novel genes mutated in these syndromes. So Sharon, thank you very much for Zooming with us today, and we're looking forward to your talk.
Thank you very much, Luis, for the very, very kind introduction. And yeah, I do have to say that that mentoring award is probably the best one and really the most important one. And it's something that I take very seriously as far as our collaborative efforts as well. And so as all of you are listening today and thinking of ideas and hopefully learning some things, I want you to know also to feel free to reach out to me with any questions or comments about whether it's about a patient, whether it's about biology. I'm always happy to talk and to develop new studies as well. So wanted to give you just a very quick overview of the clinical cancer genetics that we do here in the intramural program at the NCI. So I'll be focusing on our marrow failure program, but I also have a Li-Fraumeni syndrome study that's open and accruing. Dicer-1 syndrome is led, and RASopathies is about to launch, and those are led by Doug Stewart, who's a medical geneticist in our branch. And then we have a host of other long-term studies that are really built on 30+ years of follow-up since in the very beginning of clinical cancer genetics. And we're always interested in looking for new folks who are interested in training in clinical cancer genetics and also in genomics, basic science, et cetera, in epidemiology, of course. So our clinical cancer genetics program really runs this way. And we really start by accruing participants from the field, meaning that patients or their family members can call us and start the referral process. The referral nurse asks them a series of questions depending on the study. The study team reviews and says, yes, they're eligible, or no, maybe they're not, or we need more information. If they're eligible, we send consent forms and questionnaires. And those include a detailed family history and an individual history questionnaire, again, all tailored depending on the disorder that's being studied. All of those people become part of our field cohort. And that's those are people who we actually haven't seen yet at the clinical center, but we work very closely with them. And we get the records, we work with the doctors at home, and we also collect biospecimens from the field. That could be blood, saliva, tumor samples, bone marrow, et cetera. And then depending on the study, a subset of participants will come here to Bethesda, to the NIH Clinical Center for evaluation. And again, it's all tailored based on the study. And I like to show this photo because this is one of our Li-Fraumeni syndrome pedigrees. And this is one family on many, many pages of paper that we were able to piece together, hundreds of related people. And this approach really helps us understand the germline genetics and the phenotypes associated with these disorders. So our bone marrow failure syndrome program opened in 2000, and Blanche Alter is the PI. And as Louise said, I started working in the clinical genetics branch in 2006. And at that time, I took over the Dyskeratosis congenita and telomere biology disorder section. And the idea was really to identify the genetic causes of these disorders, to do a long-term study, which now we have nearly 20 years of follow-up data on some patients, to understand the basic biology and also to build a collaborative resource. And as I said, I think this is probably one of the most important things that we do with our biospecimen repository, data collections and sharing throughout the world. So getting to Dyskeratosis congenita, how was it first described? In 1906 was where we can figure is the first paper that was published in a dermatology journal that described a phenotype of dysplastic nails, oral leukoplakia, and abnormal skin pigmentation. And then in the early century, additional papers were published. And initially, the majority, the cases were thought to be all male because those first papers just had males. So we thought it was an X-linked disease back then. And this is a very typical X-linked pedigree that you can see the grandfather here. This is the mom. Her father had classic features, dysplastic nails. He had bone marrow failure and he died at age 32 of that complication. She was perfectly healthy, but unfortunately, she had 3 affected boys who have all had classic features of DC, and we're going to talk about those moving forward. So if you see lots of these pedigrees, you're going to think this is an X-linked disorder only. But in the 1960s, the first report of a female case came out. And again, as we start ascertaining more and more families and pedigrees, we realize now that it affects both genders. There is a slight predilection for males because of the X-linked gene, but there are also many other genetic causes of DC. And so both genders are now roughly equally affected. So Dyskeratosis congenita, or DC as I'll call it, was the first human disease to be connected to abnormal telomere biology. The mutations in Dyskerin, or DKC1, were first described by Indrajit Dogal's group in the late 90s. And subsequently, Kathy Collins and her group showed that those patient mutant cells had very low telomerase levels and very short telomeres. And this is the holoenzyme complex that I'm going to touch on. And so talk about a little bit because it's critical to the biology of DC. So what are telomeres and why are they important in this disease and in general? So telomeres are long nucleotide repeats and a protein structure that form a cap on chromosome ends. With each subsequent cell division, telomeres get shorter and shorter due to the inability of the DNA polymerase to fully replicate that 3' end of DNA, the DNA overhang. So telomere shortening is a normal part of aging. And that's something that's been very well established and very well studied. When I think of telomeres in cancer, though, it gets a little more complicated in that over time, as cells divide, you have shortening of your telomeres. And in some cases, these abnormally short telomeres can cause chromosome fusions, and cancer cells can sometimes, or cells that are destined to become cancer, can increase telomerase and other activity and other factors and continue dividing despite having critically short telomeres. At the other end of the spectrum, cells can upregulate telomeres, their telomerase and other factors, extend their telomeres, continue to divide when really they shouldn't have, and continue to acquire somatic mutations that could send it down the carcinogenic pathway. This is at the somatic side of things. When we look at telomere length in populations, what we see is a wide array of lengths. So this is a graph, and I'll be showing several of these, of telomere length measured by flow cytometry with FISH in white blood cells. And this is lymphocytes. These are based on hundreds and hundreds of healthy individuals where from age 0 to 100, we've established with Peter Lansdorp, who was at the University of British Columbia, the 1st to 99th percentile ranges of normal telomere lengths in populations. But what I want to emphasize is that even in people without DC, without a telomere biology disorder, there's a wide range in normal telomere length. And this is because there's a lot of factors that contribute to telomere length and telomere biology in all of us. So common variants are associated with telomere lengths, environmental factors. And what I'm going to be focusing on now are the rare variants and the rare diseases that have been so informative in understanding biology. So the diagnostic triad of DC is characterized by these dysplastic fingernails and toenails, but I want to emphasize that sometimes patients don't have these features, or these are features that develop over time and progress. So you could see a patient whose nails look perfectly normal, and then 5 years later, they start looking cracked and dysplastic. Same goes for the skin. So the classic description is reticular skin pigmentation of the neck and upper chest, but we now know that it occurs everywhere, the entire body, no area is spared. Sun-exposed areas tend to be more severe, but you see hyper and hypopigmented areas. The other part of the diagnostic triad is oral leukoplakia, these white spots in the tongue and in the buccal mucosa. And in other disorders like Fanconi anemia, or even in the general population, oral leukoplakia can be a precursor to oral cancer. In DC, it's a little more complicated because patients are at risk of head and neck cancers, but these lesions are a little bit different and are followed closely. So in addition to the mucocutaneous triad that I just described, patients with DC are at very, very high risk of bone marrow failure, of pulmonary fibrosis, of cancers that I'm going to touch on, liver disease, enteropathies, stenosis of the esophagus, urethra, lacrimal duct. Some patients have central nervous system abnormalities. And we diagnose it by telomere length less than the 1st percentile for age, and I'm going to show that. And we also know there are now at least 14 different genes and all modes of inheritance. So in our cohort to date, we have a total of 133 families. And again, in our studies, in all of our studies, we don't enroll just the affected person. We try to enroll the entire family because we want to know what's part of having one of these disorders and what's just part of being a member of that family. And that's been incredibly important as we try to understand these phenotypes. So we've seen about 40% of the patients and families at the NIH Clinical Center, which has also provided us a great way to phenotype patients in detail. So many years ago now, and this is now well established, the diagnostic test for DC was really developed by Blanche Alter in our group and Peter Lansdorp and Gabriela Berlacher from Vancouver. And what they showed in the first and subsequent follow-up paper is that if you do measure telomere lengths by flow fish in white blood cells, lymphocyte telomere lengths less than the 1st percentile for age were highly sensitive and specific for differentiating patients with DC from their unaffected relatives and from patients with other marrow failure syndromes. And that's really shown visually here, where the colored symbols are all the affected patients who we have a confirmed diagnosis. And you see some of their relatives are here too. And that's because at the time, which was now 8 years ago, we didn't know the genes in those families, and we do now. So we use telomere length. And if you have a patient who presents in a young age with pulmonary fibrosis, with aplastic anemia, and by young, I mean under 40 for sure, I would do telomere lengths in addition to the regular workup. So as time went on, and the first gene was Dyskeratosis, that first connection to human telomere biology. Subsequently, mutations in Telomeres, which is TERT, and TERK, its RNA component, because telomerase is a reverse transcriptase, were described in both autosomal dominant, and TERT can also be recessive, and that patients are biallelic. So around 2005 or 6, these were described. And then when I first started working on this, I love to show this story because it shows the power of genetics and also of looking at phenotypes in a different way. So we identified this family in our study where the proband was this young woman who was in her 20s at the time who had classic features of DC. They had bone marrow failure, they had the skin findings, etc. Her father had an identical twin brother. They both had classic features and passed away of DC-related complications. She had 3 affected cousins who also had clinical features. But when we measured telomere length on the entire family, everyone who we were able to at the time, we noticed that the proband had 2 brothers who also had very short telomere lengths. Now, at the time, they were clinically unaffected and they were still quite young. So instead of using the heterogeneous phenotype in this family, I used telomere length as my phenotype in a linkage scan. And this was before we were exome sequencing everyone, which was really only 14 years ago or so. We found that autosomal dominant or heterozygous mutations in a gene called TNF2 tracked with the phenotype. And TNF2 has since been shown to be one of the most commonly mutated genes in DC. It is predominantly de novo. And so TIN2, we could have whole sessions on this, is a component of the shelter and telomere protection complex. And it's part of the 6-protein complex that is essential for helping to cap the ends of the telomeres and keep them stable, keep the telomeres from fraying. Now, I'm going to jump ahead and show you lots of other genes that are now associated with DC. And this very colorful diagram is here really just to show you that in the telomerase enzyme complex, there are now many genes associated with DC in both recessive forms and heterozygous or dominant forms. And also in the sheltering complex, additional genes have been identified. Now they're more and more rare in patients, but they're still incredibly important. The same goes for the CST telomere capping complex. I'm just going to tell you a brief story about our RTEL1 work, because I think it has important implications for patients and families at all levels. So when we and others kind of had a whole flurry of RTEL1 germline discovery papers at the same time. RTEL1 is a DNA helicase that's essential for telomere homeostasis and DNA replication. And we found these 6 families that had germline mutations in RTEL1. What was especially interesting was this little girl who had a very difficult to diagnose immunodeficiency, and her telomeres were very short for her age, and at the time we didn't know their gene, we didn't have the family information. But through a telomere meeting and talking with folks at one of the EMBO telomere meetings, I met John Petrini, who's at Memorial Sloan Kettering, who said, you know, we found RTEL1 mutations in another family, and we found the exact same homozygous mutations at this arginine 1264 to histidine locus. It turns out that both of our patients were from families of Orthodox Ashkenazi Jewish ancestry. So in addition to lots of functional studies, we also looked at the haplotype, and we found that this was actually a founder mutation in the Ashkenazi Jewish population. And so in collaboration with the Center for Jewish Genetics in New York, we found that in the Orthodox population, up to 1% of the people in their database were heterozygous carriers for this variant in RTEL1, which was enough to have it be put on their panel that they test for people who are of Ashkenazi ancestry in their prenatal testing program to help determine the risk of rare recessive diseases. So that brings us to RTEL1, and really where I want to come back to is emphasizing that this is really complicated, and we have at least 14 different genes at varying frequencies. We have telomere lengths less than the first percentile, and that's really what puts these complex phenotypes that I'm going to talk about together. So in addition to the first kind of slides I showed about DC, there are other rarer disorders that are part of this family. So Hori-Hall-Riederson syndrome, or HH, is similar to DC, but there's also cerebellar hypoplasia as an immune deficiency. That was what that homozygous RTEL1 patient I told you about had. Revenge syndrome has similar features, but has exudative retinopathy and intrauterine growth retardation. Now, Coates Plus wasn't part of this family of disorders until germline mutations in the CTC1 telomere capping protein were found, and it really actually fits a lot now with what we're seeing in our patients. So patients with Coats Plus have actually their major cause of death is gastrointestinal bleeding due to these GI ectasias. They also have bone abnormalities, fractures, and exudative retinopathy, and a lot of clinical overlap. Now, in general, these are all patients who present very early in life, often as very young children. At the other end of the spectrum, there are the middle-aged or even older adults who will present to your clinic, and thinking of medical grand rounds, with apparently isolated disease. So you may have a 52-year-old who only has pulmonary fibrosis, or a 44-year-old with aplastic anemia, and that's it. We also see liver disease, fibrosis, non-alcoholic, non-infectious, and actually early onset head and neck squamous cell carcinoma. We've had a couple of patients diagnosed in their early 30s with head and neck cancer that it was only until they did not do well with therapy that the diagnosis of DC was made. Similar things have also happened in Fanconi anemia. Family history is helpful, except when it's not, right? So families aren't always, we don't always know our family history, and also the phenotypes aren't always fully penetrant. And I bring this up as well, and this is why family history is really helpful, but also, you know, we're trying to figure out these subtle interactions. So this patient here was a boy we saw in his teens. He developed severe aplastic anemia at age 12. He had nail dystrophy, early gray hair, and was fit our definition classic DC when we saw him at clinic. What's really remarkable is, so his mom had aplastic anemia, but not until 33. And unfortunately, she passed away. We weren't able to test her. She passed away due to transplant complications. What's really remarkable is his grandmother, who was in her 70s when we first learned about her, had no phenotype, was totally healthy. But she has two siblings who had features that could potentially fit our phenotypes, with a leukemia and a thrombocytopenia and cirrhosis, especially at a young age, but we weren't able to get their full details. Genetic anticipation, which is progression of the phenotype over successive generations, happens in many genetic disorders, including DC, including shortening of telomeres with each successive generation. And what's remarkable here, I want to point out, is so our proband was here, very, very short telomeres for his age. They were actually similar in length to his 70-year-old maternal grandmother. So this adds complexities to when we're trying to counsel the relatives of our patients. We did do, this is old now, and I have to say I have a fellow now, Marina Nivich, who's working on updating our genotype phenotype outcome studies. So this is old data, and we have new data now on about 250 patients. But this really just quantifies and shows what we know is that the young patients who present either with recessive or X-linked disease tend to have more severe phenotypes and don't do as well as the patients who are heterozygous, who have heterozygous disease. So I want to share a new gene that we just published last year that's a little bit different, and it also is especially, I think, relevant to the adult medicine docs. So we first saw this boy as a teenager, and he had neutropenia, a hypocellular bone marrow, and some other features of DC. And we looked at his pedigree, and his mom had similar features. Notably, his maternal aunt had an AML. His cousin had a head and neck cancer at age 26, and her brother had head and neck cancer at age 38. So we did exome sequencing, and we did telomere length measurements, and you can see their telomere lengths here. Like, technically they're pretty much normal. They're not real, they're in that 1st to 10th percentile. Sometimes we call that the gray area. The cousin, her telomeres were right on the 1st percentile. What we found in this family by exome sequencing was a heterozygous variant in a gene called MDM4. Now, previously, Frank Toledo's group at the Curie Institute had shown that mutant MDM4 mice actually have a Dyskeratosis congenita phenotype. Now, MDM4 is part of the P53 pathway, which is a key tumor suppressor gene. When I saw that Frank had published this paper, I didn't know him. I emailed him. I said, I have this interesting family. What do you think? Can we work together? And it took a while because he made mice. But what we showed was that our human mutation when we modeled it in the mice, was actually consistent with a DC phenotype in that these mice had aplastic anemia, they had short telomeres, they died very early, they had abnormal lung function and formation. And so this was really a great way, and what I really like to do is combine those human phenotypes with the biology, and this was the first time in MDM4 we were able to do that. Additionally, I'm working with Yi Lu, who's at the National Institute on Aging, and we just showed also that an imbalanced NAD metabolism, so looking at mitochondrial function and oxidative metabolism, showed that our patient cells and the mice have abnormal mitochondrial function if they have very short telomeres, and that we can rescue that with improving NAD metabolism. And so now we're looking at potentially additional studies and potentially a clinical trial in our study participants. Okay, so now I'm going to talk more about the phenotypes that we see and how we've characterized them in detail in our patients. So I'm at the National Cancer Institute, and this is really the predominant reason that we started this cohort, which was to prospectively follow patients who have these rare disorders and really get a better idea of what the cancer phenotypes are and what the real incidence is. So we know very well that cancer incidence, shown here in the blue line, increases with age. Telomere lengths get shorter with age. So there's been a lot of studies, we don't have time to talk about that now, at population level, looking at telomere length in surrogate tissues like blood or buccal cells, and looking at telomere length outcome, telomere length in association with cancer and other diseases. I put this here because our patients with DC have very short telomeres. And one of the first studies that we published in cancer in our group was on only 52 patients. And I'm not going to go into the details here, but basically we showed that about half of our patients had had at least one cancer by age 60. And the majority of those were head and neck squamous cell cancers and AML and myelodysplastic syndrome. Now this, I think the next slide shows the value of these longitudinal follow-ups. So what we were able to do in our data up to 2017, so now we have 15 years of follow-up, we have 197 patients. And what we showed was that the median age of cancer onset was 38, so very young. The risk compared to the general population, when we looked at our observed cases versus the expected in the SEER cancer registry data, was 4-fold increase above the general population, with again, tongue, squamous cell cancers, AML, MDS, and lymphoma being the predominant cancers we're seeing in our patients. What's especially remarkable though, is over the last decade, our patients with DC have been doing much better with bone marrow transplant. And now we're starting to see the long-term sequelae of those, including increased risk of cancer of the same types in patients after transplant. So again, you really need to follow these patients closely. We additionally looked at the incidence of adverse events, and this was 2009, and then in 2017, where we showed the cumulative incidence of needing a bone marrow transplant or dying was about 50% by age 40. The solid tumor and leukemia cumulative incidence slowly increase with age. So another phenotype that we see often, and that is a big challenge, is pulmonary fibrosis. And again, there was actually going to be an entire session on this topic at the American Thoracic Society meeting that was supposed to have been held in the spring, but has been since delayed due to the COVID pandemic. So I'm going to tell you two different stories. So this was one of the first patients I saw with DC. So he presented at age 4 with severe aplastic anemia. And this was probably more than 20 years ago now. He underwent a successful matched related bone marrow transplant. Around age 6, his parents noticed that his nails and skin weren't quite normal, and he got a big workup for graft versus host disease, as you might expect. But then he developed pulmonary symptoms around age 11, and that's when we saw him. And we found he had a TNF2 gene mutation. He underwent a successful bilateral lung transplant at age 13. This was his lung CT prior and the explanted lung, which shows diffuse fibrosis and bronchiolitis obliterans. Now, he did quite well, but he was still quite frail. And unfortunately, at age 18, he developed a head and neck squamous cell carcinoma and passed away due to those complications. That's one severe end of the spectrum. At the other end of the spectrum is a woman who I had known really since I started working in DC. She had developed thrombocytopenia in her 30s, which progressed to pancytopenia, but she didn't have a good bone marrow transplant donor. She didn't really want to do it. And so she decided, so we treated her with oral androgens, and she actually was successfully maintained, meaning that she didn't need, her counts were not normal, but she didn't need transfusions. She subsequently was found to have a TERK mutation in her late 40s, and her family history was notable for her mother, who had pulmonary fibrosis in her 60s. And you see here in our patient the progression of her lung fibrosis here, especially on this side. And unfortunately, she passed away about 2 years ago due to pulmonary fibrosis. So this prompted us to look at our baseline pulmonary function tests and outcomes. So Neelam Gary is a staff clinician who works with me, who's really our clinical force for all of these studies. And we, part of our evaluation at the clinical center is comprehensive, and we do lots of testing. We sort of tell patients they get, a year's worth of medical tests in a week. And it's really been helpful because we've been able to ask questions about what happens afterwards. So Neelam looked at our patients when we saw them, and this is just a random set of study participants with DC. And what she showed was that if they had even subtle PFT abnormalities at when we saw them, their outcomes and their likelihood of developing significant pulmonary disease was very high, and that and their outcomes were much more poor. And this also correlated with the phenotypes of the earlier onset diseases that I've mentioned. So this tells me that baseline PFTs can be really helpful in that, at least for these patients, you'll know where they're starting. We need more data to really show this prospectively, but it's a really important aspect as we start trying to put these complex pictures together. Next, my post-baccalaureate fellow, Sonia Bala, looked at our central nervous system abnormalities. So I mentioned very briefly earlier that patients with Hoyer-Alder-Weirson syndrome, the variant of DC, have cerebellar hypoplasia, and patients with Revesz syndrome can have intracranial calcifications. What we did at the clinical center was we just had the series of patients who came to see us. There were 42 in all. Regardless of their symptoms, regardless of their phenotype, we did a brain MRI. We had them seen by neurology and by psychiatry and had formal evaluations. And then Sonia worked with Ava Baker, who's one of our neuroradiologists, to re-review all of our brain MRIs. And of these patients, what was impressive, was especially noteworthy, was that just over half had at least one or more structural brain abnormality, including cerebellar hypoplasia, which can be really quite profound. Almost half had a neurodevelopmental disorder or psychomotor abnormality. Now, these are mostly in the kids, as you would expect, right? Is the brain structural abnormalities, you're going to have these phenotypes earlier onset. And that was absolutely true. Our patients with the shortest telomeres with recessive or X-linked disease had the worst structural abnormalities. What's really important though, and this is for those adults that you may see in clinic, is that the adults who did not have structural brain abnormalities had a high incidence of psychiatric disorders, including depression, anxiety, OCD features. And these were all things that had, for the most part, been previously diagnosed before they saw us. So these are clinically very significant for these patients, and it's something that I think all of our patients really need to understand and be encouraged to seek help early for these conditions. Additionally, again, the phenotypes, as we're studying these families and understanding the genes and the telomere biology, the phenotypes spectrum is growing. Now, a couple years ago, we published a paper on pulmonary arteriovenous malformations in our patients with DC, because what we had noticed, and again, this comes back to kind of one patient and an astute clinician, in that one patient with Hoyer-Alder-Weirson syndrome, who I've known for a long, long time, over time, he developed shortness of breath and hypoxia. He had a workup, kind of traditional workup for pulmonary fibrosis. The CT was normal. His PFTs weren't normal, but weren't like consistent with anything. And it took a while, but we eventually found out, looked at he saw cardiology, pulmonology. A really smart person did a bubble echo and found that he had microscopic pulmonary arteriovenous malformations. That prompted us to look at a case series in our international consortium, the Clinical Care Consortium for Telomere-Associated Ailments. And we found that of 13 patients who had pulmonary AVMs, 12 of them were microscopic. Only one of them had an AVM that was big enough to allow interventional radiology to coil it. And then she actually had remarkable symptom relief, of course. So as we were putting this data together, I said, let's have a workshop and bring all these vascular and telomere biology basic scientist clinicians together and think about this, because the biology is something we still don't quite understand as to why there's abnormal vasculature in these patients. So Ryan Himes, who was at Baylor, who's now in New Orleans, is a GI doc who we recently published a paper on the incidence and outcomes of gastrointestinal telangiectasias and bleeding in patients with DC. This again brings it back to that phenotype I mentioned of the Coates plus disease. And what we basically have found is that our patients are doing much better after bone marrow transplant, but they're developing these other complications. And we're still working on sorting out how much is related to the transplant versus the natural history of the disease. Additionally, several patients have been reported now who have had liver transplants because of either fibrosis and usually it's hepatopulmonary syndrome. And so with the consortium, we're collecting data, and Cass Myers, who's in Cincinnati, is leading this effort of liver phenotypes and outcomes after transplant. Because again, a lot of this in this disease, we're still in that learning and defining phase. So to bring it back to treatments, how do we manage these patients? What can we do? How can we help them? So this is a retrospective look at patients in the Center for International Blood and Marrow Transplant Research Registry, which is where all bone marrow transplants are now required to be registered across the country. We looked back at patients who were transplanted between 1981 and 2009. And what we found, of course, there's only 34 patients here, but the probability of 5-year survival was very poor, with only about 65% who were transplanted in the first decade of 2000. Now, this and others have published similar things and similar lit reviews and case series. So I just want to point out a couple of key things as far as the bone marrow transplant need for patients with DC. I said they have very high rates of bone marrow failure, and there's some key pieces in that. There were high rates of morbidity and mortality, but now a protocol that's been developed by Suneet Agarwal, who's at Boston Children's, and it's now a multi-institutional and international study. So if anyone wants, I can connect you with Suneet as needed to learn more about it, but he has a non-ablative conditioning regimen with fludarabine and alemtuzumab. And patients are doing quite well. I think the longest patient out is more than 5 years. And so far, it looks like the outcomes are much better. One of the key things, though, to remember is if you have a patient who has a potential sibling or related donor for their transplant, it's really important to make sure that person doesn't have short telomeres and doesn't have the same gene mutation. So I mentioned that there's this variable penetrance of the phenotype, and this is exactly what we've seen. So there are reports in the literature of patients who had a bone marrow transplant from a sibling, and this was before we did as much genetic testing and panel testing. And what we found was that if the related donor also has the disease, the patients don't do as well as you would expect, because their bone marrow just doesn't have the ability to replicate. So it's really important to do telomere length testing and genetic testing on any potential related donor. So there are also a lot of patients who either aren't ready for bone marrow transplant because they have too many comorbid conditions, and maybe it's too risky. They have insurance issues. Maybe from a lifestyle perspective, I have a patient who didn't want to have his bone marrow transplant until he graduated from high school, and his transplant was his gap year. And that worked really well for him. So androgens have been used to treat bone marrow failure for decades and decades, and they have been used in acquired aplastic anemia, not as much anymore, but in Fanconi anemia and in DC. So Payal Kincha, who's a investigator in my group, looked at just retrospectively at the data we had collected on our patients. And she found that 11 of 16 patients who were treated with androgens, now at the time it was mostly oxymethylone, a couple of danazols, and a halotestin, had a hematologic response, meaning that they no longer needed transfusions for red cells or platelets. There were liver-related toxicities as well as splenic pileosis in a couple of patients who were on G-CSF as well as androgens. Importantly, as well, is there significant potential for liver toxicities related to the development of adenomas and even those developing to carcinomas. So those need to be followed very closely. And then, of course, there's significant abnormalities in lipids when you start someone on androgens and other masculinizing side effects. So we thought, well, this was interesting though, because at least we have some quantitative data that these patients are having a hematologic response. And so this was a small study, but we looked at the telomere length, and this was at about 5-year intervals of patients who were treated with androgens and not treated. And what we found here was that the telomere length seemed to continue to shorten, regardless of whether they were on androgens. Now, this isn't a small study, it's observational. And so I want to also point out a study that got a lot of interest and press a couple of years ago from Neil Young's group, who's also at NIH. And they use danazol, so it's an attenuated androgen for patients who had short telomeres, and they could have had aplastic anemia, pulmonary disease, other features. And what they treated patients with danazol, had for a year, and then looked at their clinical features as well as their telomere lengths. Now, their study suggested that telomere length increased a bit for patients who are on danazol, and then when you took them off, it decreased. Now, it's very difficult to compare this data to our data because they use a different method of telomere length measurement, used qPCR, which is less sensitive and more challenging related to DNA quality. So they're doing they have a current open clinical trial for danazol as a follow-up, and it'll be interesting to see where that comes at. As that came about, we looked again at our cohort of patients again. And this time we had 9 androgen treated and 12 not treated. And I just wanted to show here that at least in our study, which is an array of ages, an array of phenotypes, it looks like telomere length continued to decline as you would expect with patients on androgens. Now, that may or may not actually really make a big difference, because the key part here is that the patients on androgens no longer need it, often respond and don't need red cells or platelets. Sometimes we even see a little bit of improvement in their white count. So I still think that androgens can be used as a bridge to transplant, or in patients who maybe can't have a transplant for one reason or another. And that's kind of where we're at right now with those patients. So I'm going to start wrapping up, and I thought I would share this case. And I know it's medicine grand rounds, but I'm a pediatrician, and also eventually these kids grow up. And so I want to share this case of a patient I've known for a very long time. So he was born at 36 weeks gestational age and had some complications related to reduced fetal movements, a small placenta, and oligohydramnios. You can see he had intrauterine growth retardation. He was only 3 pounds 9 ounces at 36 weeks, but he went home and did okay for the first few weeks. At age 6, he was hospitalized for at age 6 weeks. He developed respiratory distress, was found to have severe anemia and cardiomyopathy that was thought to be due to this anemia. But the etiology wasn't known. So he got support and seemed to be okay. His early infancy and childhood, though, continued in that he had gagging and reflux in infancy, and he had his first esophageal stenosis dilation at about age 1. He had white spots on his tongue that had a biopsy that were thought to be pyogenic granuloma, but he continued to have those, and it turns out that was Leukoplakia. He had very early onset of nail dysplasia, fingernails and toenails, and even saw dermatology who noted thin and brittle nails. He also had delayed developmental milestones with truncal ataxia, microcephaly, and cerebellar hypoplasia. So he had a big workup for mitochondrial or metabolic disorder. And this was about 15 years ago now. So before we had all of these genes that we have in for DC. And so you can imagine this is a really long diagnostic odyssey for this patient who is now 20 years old. So at age 3, he developed thrombocytopenia, and initially it was thought to be related to lisinopril because he was on that for that cardiomyopathy, but it didn't improve when they took him off. He saw hematology where he had macrocytosis, which sometimes we do see macrocytosis as a hint to having an inherited marrow failure syndrome. He had some mild anemia, thrombocytopenia with platelets, sorry, this should be 39 to 80,000, and a hypocellular bone marrow. So over time, his bone marrow failure progressed. And when we saw him, he was, for the first time, he was about 10. And this was as telomere length testing was becoming available for patients. And you can see how extremely short his telomeres are for his age. His telomeres at age 10 were shorter even than an 80-year-old's telomeres. So his bone marrow failure is progressing. He needs a transplant. His brother was a match. His younger brother was a great bone marrow match, but he had short telomeres, not quite as short as the patients, but still not normal. And we had lots of conferences and said, you know, we don't feel comfortable having this brother be a transplant. At the time, though, we didn't know the gene of this family. It hadn't been discovered yet. So the family chose to treat him with androgens and postpone the transplant as long as possible, mainly because, again, they wanted time to get him through school. They wanted time to learn about their gene, time to improve transplant outcomes. So he continued with androgens, had esophageal dilations every couple of years as needed. He had an IEP at school and was doing pretty well. And I want to show you this progressive and expansive phenotype that he had over time, because it's important. And you can see at age 7, and I could have put this at age 27 for some patients, because some patients develop these things later. But at age 7, he had some skin pigmentation abnormalities. You can see his toenails are really already dysplastic and disappearing. And at age 18, his skin phenotypes continued to progress. This prompted us to also work with our dermatology colleagues at the clinical center, and we did some quantifications and really detailed evaluations of the dermatologic phenotype. And we found that it's more than just, you know, we talk about the nails and the skin, but there are a lot of additional abnormalities, including hyperhidrosis, hyperkeratosis of the palms that can be incredibly challenging for the patients. Epiphora due to watery eyes because of lacrimal duct stenosis, and they get irritation around their eyelids, abnormal eyelash growth, which can cause corneal abrasions and scarring. And this, of course, is worse in the patients who present earlier. But these are also important quality of life things that we want to make sure we track for our patients. So I want to leave you with some questions on this slide. In that, this was our proband that I just told you about. He and his telomeres. And at the time, before we had his gene, we also measured the parents' telomeres. This is mom, this is dad. So moms are borderline, dads are on the 10th percentile for his age. Clinically, we evaluated the parents, and at the time they were in their mid to late 30s, perfectly healthy, no problems. Same for the brother. The brother is a incredibly healthy, robust football player. Now, we found their gene in 2013, and the proband has biallelic RTEL1 mutations. So he has a stop codon that he got from his mom, and he has a missense mutation that he got from his dad. And his brother has a stop codon as well. So I know exactly, and unfortunately I can predict our proband's outcome is complicated. and he is going to have a shortened lifespan. He's in college right now though, and he's doing great. He, is really working hard. So how do I counsel his brother, who is now in high school, or his parents who are still relatively young? They're under 50 now that we've been following them. And we know that heterozygous RTL1 mutations are associated with the development of pulmonary fibrosis later in life, with a potential for aplastic anemia at some point. And so one of the big questions that we're asking, and we're really working with our international consortium to follow up, to study these families and really try to understand, how do we best guide them? We've tested the grandparents. Grandparents are carriers as well, but they're healthy and they're grandparents. So I think we have a lot to learn about genetic anticipation in these families, and also about how to counsel the other maybe less affected individuals. So along those lines, I want to point you all to the Team Telomere website, which is where the clinical care guidelines, diagnostic guidelines is at. It was published in 2015, and we're currently updating that now. You can download the PDF for free, and it has all these details that I've touched on. And then lastly, just I want to touch on telomere biology and human disease. For the most part, I've been talking about these very rare disorders with very rare variants and very short telomeres. But just very briefly, there are rare disorders that are associated with rare variants in telomere biology genes, but have very long telomeres, including familial melanoma and familial chronic lymphocytic leukemia families. And then when we look at the general population, if you look in the literature, there's hundreds and hundreds of papers looking at telomere length in population studies associated with various diseases and outcomes. So it gets really complicated really quickly, and it's really important to look at the methods and the populations being studied for all of these disorders. And with that, I want to say thank you, especially to our patients and families who have a long road, but who are really our inspiration for everything we do, and especially our marrow failure team here at the NCI and all our amazing collaborators on the basic science and clinical side. Thank you very much. I'd be happy to take questions.
Thank you so much, Dr. Savage, for that fascinating look into these telomere disorders. Everyone can feel free to submit questions via the chat or the Q&A tool for us to review. I will go ahead and get started with a question. I can start my video as well. I found the use of androgens to be fascinating. I didn't realize myself that that was a potential bridge to transplant. Is there a role for corticosteroids in these patients, or is that not as effective?
Right, that's a great question, and they're actually corticosteroids don't work. So they're and actually I didn't mention that either. So corticosteroids for bone marrow failure in these patients don't work, and also immunosuppression with other modalities also doesn't work. And that's because, so in acquired aplastic anemia, immunosuppression works because because a lot of those diseases are immune mediated, right? So you basically kind of reset the immune system, you can get improvement in the aplastic anemia. But in the inherited setting, it doesn't work. The one exception for corticosteroids is in Diamond-Blackfan anemia, in which those patients respond to corticosteroids in infancy and in early childhood, and that is has a very different biology.
Great, thank you for clarifying that with me. One other question just came in. They say, thank you for your talk. Is the length of telomeres different in different cell types throughout the body, or is it relatively consistent?
That's a really good question too. So in different tissues throughout the body, the absolute telomere lengths are different, because telomere length is often related to the cellular replicative potential. So telomeres, say in the brain or in the heart, that the cells aren't actively replicating, those telomeres may be longer than, say, in the gut or in the skin. But what's really important to note is that the telomeres in an individual are highly correlated. So if a person has short telomeres in their skin relative to another person, they're going to have short telomeres in all of their other tissues. So that's an important caveat. The absolute values can be different, but the correlations are very strong.
Great, thank you for that. One other question, again, they thank you for your awesome talk. And then the question is, what is the mechanism for developing ILD? Is it a response to infection or inflammation?
So there's so many good questions and so many things we don't have the answers to, right? So for interstitial lung disease, the specific role of telomere dysfunction is still something that's being discovered in that, so I always come back to several years ago, I went to a small pulmonary fibrosis meeting, and I thought, I'm a pediatric hematologist oncologist, right? So I thought, I'm going to learn so much about lung fibrosis and how this is all putting it together. And then I found that, we don't know a lot about ILD in general, let alone the specifics of telomere biology in that setting. There are some hypotheses though, in that the idea is that, and this goes not just for the lung, but even for the gut and for and bone marrow potentially, is that the stem cells or key cells that are dividing and creating the normal matrix, the normal alveoli and the normal parenchyma, because the cells have reduced replicative capacity, they kind of run out, the way I think of it is they kind of run out of steam earlier than they should. And so those cells, when they get critically short telomeres, they'll often either apoptose and die, which then they kind of get replaced by fibrosis, potentially, or they don't die, but they undergo senescence. And senescence is not a quiet state, actually. It's a pro-inflammatory state. So that's another hypothesis that's being tested as to, I think what happens is the cells are kind of running out of their ability to replicate, and they're doing their best. They're trying to make appropriate lung cells. They're trying to make in the GI tract, I think what we see with the bleeding is potentially the endothelium sort of just trying to remodel, trying to put together what it can. But there's a lot to learn. The other thing though to know as far as the interstitial lung disease related to telomere biology is that there have been very few studies that have looked at the antifibrotics in patients with short telomeres. There's, I think, only Christine Garcia who's at Columbia now, has done some of those studies more recently. And we don't have any reason to think that, again, like with the bone marrow where immunosuppression isn't going to help for these patients, we also don't think that immune modulation in pulmonary fibrosis for these patients will work. But again, the studies still haven't been really fleshed out.
Okay, great. I think that's
Sharon,
most of, oh, go ahead.
I have one more question, sorry. Sharon, great talk. I was wondering, what is the percentage of unknown patients that you still have? I saw your graph there, but I was just wondering how many are still unknown in terms of their mutation.
So in our cohort of about 160 or so families, it's about 20% are still unknown. And so we have an exome sequencing pipeline and on the research level. And even with our exome sequencing, we look and I think we've kind of maxed out. We have a couple other rare genes that we're looking at, but we still have some gene discovery to do. The challenge though is in gene discovery is also the phenotypes. So the phenotypes are different, the genes are different, and even the discovery now that we've found the majority of cases gets even harder.
Okay, see. So, and do you think that these mutations could be non-coding regions then?
They could be. And so one of the things we want to do moving forward is to start doing more comprehensive whole genome sequencing. But the challenge with any rare disease is, as I showed, like in the MDM4 family, that's one family that's been published to date, and it was about 5+ years of work for one family. And so, it's challenging to also think about how to invest your time as you find these potential new loci as well.
Thank you very much, Sharon.
Thank you so much, Dr. Savage, for that very comprehensive and insightful talk on all the work that you've been doing. I think we'll wrap things up now. If people have follow-up questions, you can feel free to reach out to me or Dr. Batista, and we'll make sure that those get forwarded along. Thank you.
Okay, thank you very much.
You can feel free to sign off as well.
Okay.
Thank you.
All right.